So we have a good abstract which were presented by the previous speakers. So we'll not go into the details of each and every result, but I would like to start by saying that we all know that small cell lung cancer, because first the abstract presented by Naveen was following up on the small cell lung cancer. It constitutes 10 to 15% of all lung cancer. We divide them into the limited and extensive stage. And for limited, the concurrent chemoradiation therapy is the standard regimen, and RT dose to a dose of 60 to 66 gray in OD regimen, or 45 and 30 is the BID regimen, and PCI in patient with any response. So I just wanted to ask my panelists, right from Dr. Roshni to Dr. Nikhil, how many small cell lung cancer do you see in a month? Anyone or all of you can answer. Please take the mic. How many small cell lung cancer have you seen in the last 1 month? Maybe at the limited stage or extensive stage?
Counting both whatever limited or extensive, maybe 1 or 2 a month maximum.
Nikhil?
Same, around 10 to 12 in a year.
10 to 12 in an year, yeah.
I have seen only 1 or 2 in a year.
Okay.
That also metastatic.
Dr. Vivekanand?
Yeah, I agree with Deepanjali. I see 1 or 2 a year.
Okay, Bhavin?
Single digit in a year, not more
Single
than that. And
digit.
most of them are either metastatic or extensive stage. So limited stage, probably 1 in a year, that too in a very good year.
Dr. Roshni, ma'am?
Same thing, 12 per year and about 90% extensive stage.
Yeah, so maybe 1 or 2 in a month, at the max. Naveen, you want to comment? How many do we see small cell lung cancer, both included?
Probably around 40, 50 patients is what we would see in a year. Most of them would be extensive stage. I mean,
Okay.
more extensive.
Yeah, so we also don't see a lot of limited stage small cell lung cancer, maybe hardly 10 in a year, as all my panelists say. And how do you define a limited stage? May I ask with the Nikhil or Tinanjan can answer that? How do you define limited stage? It's just for the sake of audience, because I think we have not covered that.
So we defined traditionally as a disease which can be encompassed within a radiation portal. But now with the era of the VMAT and the IMRT, so we try to see if we can safely deliver the radiation with respecting the lung and the other critical tolerance. So that we can.
So anyone wants to add anything, or all of them agree?
You actually have put what is to be added. You already have added that. Yeah, so this is very much. But yeah, it's very true. Like Naveen also said, if you ask limited, it's really rare to find. Very, it's most of the time we see extensive.
Okay. Why I'm asking is that because we have always seen that in the 2-dimensional area or in the 3-dimensional area, it was the safe radiation portal. Now, so many of us feel that with the help of IMRT or VMAT, everything is safe. But it's not exactly the same that every disease will not be safe. Yes.
3A or 3B, that's what you mean? Max.
According to the current 8th edition, it will be 3C also. If there's N3 nodes. So supraclavicular node will be considered as the limited stage if it's in the upper lobe location.
Anil, if I can just
Please.
add. So even pleural effusion classically is included in the limited stage according to the VLSG.
Yeah. So pleural effusion is a controversial topic. I just did not want to mention because of the deviation. So this was the trial presented or abstract presented by Naveen, and we all know that this is a retrospective study, twice daily IMRT with the SIB technique, GTV 57 gray, more or less 2 gray per fraction, 4 gray per day, and the propensity score match analysis, very small study, 37 patients each. Primary was PFS, but the outcome, if you see, is excellent. Means I haven't seen any some outcome data even in a retrospective study. The PFS is double, the OS is double, overall response rate is 95 to 97%. However, the grade 3 toxicities were very high, 43%. So my discussion to all my panelists, how relevant is the BID regimen in your clinical practice? Do you practice in 1 or 2 patients that you get to see in a month? Have anyone practiced BID regimen? If not, then what do you practice?
So we generally practice for lung 60 to 66 gray for a limited state disease. BID we have used for few patients in head neck, but in lung never.
Dr. Vivekanand?
Same 60 gray in 30 fractions would be, BID is not, logistically possible because of the number of patients in, we have a single unit set up in our hospital, so it's not possible.
It's just the logistic, or it is the fear of BID regimen?
No,
So because of the
it's
toxicity.
logistic. We have done initially in early 2000s, we used to do because of the chart regime. But after that, we have never really practiced.
And Dipanjali, Naveen,
So,
sorry, Yatiranjan.
so no experience, first of all, with small cell lung cancers being treated. But if I had to treat, I would treat with OD dosing, which is 60 to 66 in 25 fraction, a hyperfractionated regime.
Okay. Yatiranjan,
We also treat with 60 in 30 for a patient which we had just completed yesterday. So we were planning to treat with that hyperfractionated regime twice daily. He was an elderly man, responded nicely to the induction chemo, around 80 years. So we wanted to finish it off fast and send him back. But again, fear of toxicity. So we thought it will be difficult for us to manage the esophagitis. So we decided to go for a conventional fractionation rather than the hyperfractionation.
Yatiranjan.
I feel, yeah, the logistic comes, but also the point is, see, we hear a lot, like Naveen very rightly said, that this is one site, probably really one site now where hyperfractionation has a benefit. And this is one very rare site where there are many studies also to prove that. But it is traditionally, we hear logistics reasons. So what has happened, I think, for many of us, that from your training days, you hear this is a logistic challenge. So nobody has experienced it, doing it. So then that goes into your mind that it is a logistic challenge to do it, and which is also true in a very busy setup. But for last 2 decades also we keep on hearing this is a logistic challenge, and we have never experienced also doing it. So both the things have not come up, your experience and the
I think just the logistic is just to say the logistic will not be the correct way, because we are treating 120 patients in a day on a machine. So if you are asking, or if you are just saying that the logistic is the reason that we are not treating, may not be, because as Naveen said, the onus is on us.
See, issue is that only for a TBI or a TMLI, we are treating twice in a day for 2 hours a day. So that we are able to manage. So logistic is not the answer. The issue is that
No,
we don't have an experience of
it's
treating.
not only the machine, it's the patient has to wait for about 6 hours, and they have to be willing for the so many days, even if you consider.
But it will be completed in a 3 weeks time as compared to 6 weeks.
Yeah, but,
No, but-
that 3 weeks is another new regime. Otherwise,
No,
it's
but
5
the
years.
single unit is a challenge. See, if you're like Nikhil said, if you're doing TBI or TMLI, you're done in 3 days.
Yeah.
But to do it for 3 weeks in a single unit, you're treating close to 90 patients. It's really a challenge to call someone twice and take slot. Yeah, that's true. Yeah.
So Bhavin, you wanted to say something?
Yeah, I think rather than logistic, I think it is a fear of toxicity that we are all afraid about. And in my whatever small experience of head neck cancers where we have treated BID, we have realized for a younger fit patient also the management of acute toxicity is a problem. So here also probably the fear of toxicity plays in the back of our mind while deciding whether it is a single dose, single fraction or a BID fraction.
Yeah.
We are giving CTRT along with it, so esophagitis is going to be more, and again, giving chemotherapy and then going for the radiation is again an issue.
But all the studies which have shown, say for example, Convert trial, they have shown the esophagitis rate is more or less the same in the trial setting. But I must admit that, so whenever because I have treated the BID regimen, but the toxicity rate, the esophagitis is much, much more higher as compared to whatever in the clinical trial setting. In the real practice, it is more or less approximately 30 to 35%, and the patient will have a very tremendous, troublesome time. So while they are receiving the BID regimen, why I'm especially focusing on the BID regimen is that because they have shown an excellent outcome, and we have seen the Gronberg trial, as Naveen has said, that the 60 gray regimen or the 60 gray in 40 fraction versus 45 gray in 30 fraction has also shown an improvement in the 2-year overall survival. So we are somehow will get the phase 3 result if, for example, then you will have the opportunity to treat the BID regimen. Then what would be your point then? Because if you see the Gronberg trial, this is the Gronberg trial, and they have shown that the median overall survival is uprising from 22 months to 37 months. So which is more or less similar to the SIB versus the IMRT technique. So this is the comparison between both of them. Still Gronberg trial a little bit lower as compared to the Sun et al. But still, the 22 month versus 37 month, the median PFS 11 month versus 19 month in the 60 gray BID, so which is also not a comparative for the convert trial also, if you see the convert trial result. So the 60 gray BID regimen has given you a much more overall survival. It is a small phase 2 study, 170 patients more or less, but BID regimen is going to change, do you think? Or it is going to be the OD regimen because of the logistic only? Or the fear of toxicity?
What is our TMH data and what is the data in the private sector? Like Dr. Kannan is doing twice daily radiation.
I'm not
So
sure
how
Dr.
does
Kannan.
it compare to the international data?
Srinivas has a point. Yes, Srinivas.
Cancer. Also, we see 75% grade 3 toxicities. Esophagitis is a concern, there's no doubt about it. Not, you don't choose that for a very elderly patient,
But for
a
fit patient.
slightly fitter patient, I always push. Sometimes when patients say, no, I don't want to come second time. I don't mind going for 6 weeks. But I tell them that the outcome could be better with twice daily, and I try to push it. So last 4 or 5 patients whom I have treated with BID.
Yeah, that's a valid point, because if you want to push in a very fit young patient, we might be able to deliver that. Naveen, you want to comment on why we don't practice BID regimen?
So I think it is all that mindset that we are concerned about dysphagia, because patients are getting etoposide along with it. So we are definitely worried about dysphagitis. The only patient I have treated was a patient who had a T3 N0 disease, which is very rare for a small cell, but still that patient ended in trouble for a different reason. But just coming back to your earlier question about between 1640 and SIB, although the Grönberg study did show a higher dose with BID was better, I would probably lean more towards the SIB regimen, because again you are finishing off your treatment in a shorter duration, because we discussed about the logistics and
Yeah,
so 3 weeks is still probably
the overall treatment time is still less with the SIB technique. Okay. So we will move ahead from the BID regimen and the OD regimen from the small cell lung cancer. And there's a meta-analysis also which shows that the OD regimen and the BID regimen are more or less the same, but they are slightly numerically better as compared to the OD regimen, BID regimen. So this is the second trial which was presented by Dr. Mohit Sharma, long-term survival and competing risk of death in the SPACU randomized phase 3 trial in stage 3 non-small cell lung cancer. This was the original paper published. We all have read that. The 5-year overall survival, if you can just highlight that, 40% in the definitive CTRT arm versus 44% in the neoadjuvant chemoradiation therapy followed by surgery. This paper was published in 2015 JCO, and the Pacific data came in the year of 2017, which was with the addition of the immunotherapy. So we are going to discuss about that. This was the result of the consort diagram, 15 so long-term survival in the arm A and the 16 long-term survival in arm B. 10-year overall survival. Has anyone read or seen a 10-year overall survival data in stage 3 non-small cell lung cancer, leave alone the stage 1 non-small cell lung cancer treated with SBRT? Your take on this particular data? It's a randomized study. It was a phase 3 study, closed early due to slow accrual and the lack of funding, but they have a 5-year overall survival and 10-year overall survival. What is your take on this, Dr. Thinanjan or Vivekanand sir?
My take would be after the 10-year that I don't think there's much pressing need to push for tri-modality. With induction followed by CTRT would suffice for this cohort. Because eventually after 10 years also we are not getting any difference in any of the parameters.
Okay.
So why to use tri-modality?
But if you see the biomodality treatment and not the immunotherapy, so you do not have the biomodality treatment.
That's minus that.
Yeah.
Minus
by the
that.
patient themselves or by the nurse.
Just for
Nurse
current I'll
to
be
give
a
it.
surgeon. Why not
And
surgery?
it's in Hindi or some local language. I mean, neuropsychological problem,
radiation
severe
also
dementia
is
and all is
the
okay
same,
for us
do
when we ask, but in local language, how
Just
would you
to
ask this
speak-
in Hindi, for example.
I'm sorry.
Just to spare
After
one
patient,
more modality, because
depression
eventually
hai,
then
kya-
we are
what
not
do you
gaining
say?
much, right? Because a stage 3 patient of lung will,
The mic यहाँ का बंद हो गया?
this is surgeon's conspiracy.
They are still blocking us.
See, we are still surviving. So then, because they will have a lot of other medical concerns, I believe. So why to push for that?
One
Yes, ma'am.
This is in an era where adjuvant TKI and immunotherapy was not used
After
in
that,
any
definitely.
of the settings. So everything will change with
Dementia.
now with the results for future.
Okay, I will come to that. Yeah, Dipanjali. So, but if you see the biomodality treatment, just for the sake of medical oncology here, Dr. Roshni, if you see the biomodality, we generally give the weekly regimen of the chemotherapy. We are not giving the 3 weekly regimen as a part of the biomodality treatment. And many of us do not practice the consolidation chemotherapy as a 2 cycle. The results of consolidation chemotherapy is controversial whether to give it or not. Yeah, it does not make a difference. But I wanted to ask you, so because the treatment-related death is very less, 2.5%, and the disease from comorbidity was 10% and 21%. So the treatment-related mortality, so they have used the BID regimen here also in non-small cell lung cancer. Now, coming BID regimen is not leaving us. So if we are not comfortable in small cell lung cancer, the relevance of practicing in non-small cell lung cancer, where we have the chemotherapy or immunotherapy and targeted therapy in front of us, I don't see any point. Yeah.
So I would not even think about doing BID in non-small cell lung cancer. I would go with
Okay, but the 10-year overall survival is not swaying you towards.
now we have our medical oncologist friend who have come up with lot of other drugs, so which will help us.
So I wanted
One
to
more
ask.
thing I
Yes.
wanted to say is in higher centers one can practice surgery, but in smaller places this is more convenient and it shows us the results that bimodality is equal to trimodality.
Okay. Yeah.
Anil, you rightly said this was before the Pacific data. So I guess after the Pacific data in stage 3, is there really, other than very select stage 3?
So I wanted to ask my
surgery?
panelists as also, the TMS data is showing for all immunotherapy, only 3% can afford the immunotherapy. If you have a squamous cell carcinoma patient who is EGFR and ALK negative and not affordable for immunotherapy, then what will be your option? Do you treat only with the biomodality treatment? Because immunotherapy is not an affordable option still to a majority of our patient population. So this data, I think, can give us some light of hope that if you give the systemic doses of the chemotherapy, is it neoadjuvant because of the bulky nodes, for example, the patient is still not deciding about the surgery, or the patient has come to the medical oncologist, they delivered the neoadjuvant chemotherapy and then they refer to surgeons. And the surgeon said, no, I can't operate because it's functionally or technically unresectable. Then I think, I guess, I don't know what the panelists, but so Naveen, what do you think? Have anyone else wanted to ask?
I think CTRT should remain the standard. I completely agree with what just Madam said. RT versus surgery, this debate will go on, but surgery is still a very highly morbid procedure, which a very only experienced person can do, which is not available across the country. But radiation can be done safely by any good radiation oncologist, even in a tier 2, tier 3 city. So that's the major chasm that we need to keep in mind. But just to add, so in stage 3, we always said CTRT, the Pacific data is definitely impressive. But now that with neoadjuvant immunotherapy, Vijay can add there, so with neoadjuvant immunotherapy, as the IMPower studies have shown, so I think medical oncology and the surgeons are going to look more at that neoadjuvant option also. So until we have that Pacific versus neoadjuvant immunotherapy, chemotherapy, doublet, that comparison, I think this debate will continue.
Okay, Srinivas.
Who would benefit with surgery also, because there are some centers, there are good surgeons who could operate in N2 disease post chemo RT. And in fact, some centers in US are routinely doing pre-operative chemoradiation followed by surgery.
Yes.
So those who don't achieve PCR, or those who don't achieve imaging CR, I don't know, especially in the nodes, there is some data that nodal dissection after CTRT benefits. So it's probably we are going to select patients, hopefully in some centers, at least those who can do surgery, will be able to select patients better.
Yeah, so tri-modality, you still feel that in a good subset of patients, we might be able to practice tri-modality?
I was coming to that because US centers practice. There are one lung sac project, one INT data, I think they practice with NSCTRT and followed by the responding cohort. So even the pathological yield is very good in that, the nodal clearance, once you're given NSCTRT, and it's quite tolerable dose also.
Anil, I just wanted to come.
Bhavesh, please.
it is not a primary case, but we had 2-3 patients like that who were treated for locally limited stage SCLC, CTRT, excellent response for almost 1.5-2 years. Again, record at the same area, PET scan showing no other disease. And we discussed and we found that, okay, this patient can be operated, and we did operate, and these patients are doing very well. I mean, they are on follow-up, no adjuvant treatment after those surgeries, and almost 2 to 3 years, and there is no recurrence.
It is great to hear that your surgeon has operated a patient of post-chemo radiation therapy after 2 years.
So surgery is very much possible, and I mean at centers, excellent centers, like we are doing it very often now, and we are now very confident in doing all those surgeries.
Okay, point well taken. So we'll move to the third presentation, exposure of the heart in lung cancer radiation therapy. I'll not go into the detail that they have shown this much amount of result. But I wanted to ask, heart doses, is it important? Because we are going to estimate a dose of immune cells. I'm going to come to that. Heart doses, if yes, it is important, then what is important? Bhavin, you can start.
So if heart dose is important for breast cancer, why it should not be for lung cancer patient also? Heart is going to remain same. Heart is going to remain similarly for a lung cancer patient also. So if you are able to reduce the heart dose, I think we should be able to. So.
Okay, so if yes, so what is important? Dr. Vivekanand?
Yeah, now with TKS, we are seeing a 5-year of 40% survival. So if in breast cancer, we are talking of 10 to 12-year LAD problems. But here I would suggest or assume that it is the left ventricle which is more of a problem than the vessels as such.
So what do you take? You will take the mean heart dose? Yes, ma'am?
Survival improves, this thing has importance. In breast cancer, we have more patients surviving than lung cancer. So far, no one paid attention to the lung cancer heart doses.
Okay.
Now it makes sense.
But as a radiation oncologist, if you want to see, if you are saying heart doses are important, then what do you want to see?
I would say the left ventricle dose would be important. I mean, we'll have to see what it is, but we can't just replicate the breast cancer data.
The data.
Yeah. So.
And Dipanjali?
So mean heart dose as well as LED dose, though it is very difficult to keep a check on the LED dose in lung cancers, but at least monitoring those doses, keeping it as low as possible. What we have, what we follow for breast cancers, which is generally the maximum dose up to 27 gray, but of course it's difficult in lung cancer patients. Now, other is a volume-based heart doses, that is V5 and V20.
But what will be the constant that you will keep?
So
Because
I generally use V20 less than 27%, which is from the esophageal data, not from the lung cancer data.
yeah, Tiranjan?
Mean heart dose commonly, but yeah, the volumetric zones also 40, 50, 60. Try to reduce.
So
as
there is no
different
absolute
value.
cutoff that you
There's
have.
no absolute cutoff, no.
So, and there is no absolute cutoff for the mean heart dose
mean
or
heart dose try
V20?
to be 25, 26.
V20,
from across.
the mean heart dose 25.
Yes.
Okay, but if you see the breast cancer, they have a mean heart dose of less than 4 gray.
So,
So
again,
we are
that
still
will vary, that
very.
will vary with the location and all other things.
So my point is the same. So it will vary with the location. So we can't replicate the LED doses as usual.
Yes.
Because if it is a right-sided lung tumor, then there is no point of looking at the LED doses, because it is not going to be much more, or maybe not even 1 gray also. So we do not have any particular specific cardiac doses and the cutoff that they have shown. But obviously, yes, RTOG 0617, as Dr. Kostov has already said. Yes, please.
So, see, most of the data in heart came from peptic ulcer disease actually. That was the original study into some 2,000 odd patients. And whether you're right-sided, left-sided, cardiac parameters, it has now, of late, has come from breast cancer. Left anterior descending still is the most important structure, that whether lung or, if you're able to save it by right-sided, great, that means you don't have. But if you have a left-sided tumor, your left anterior descending still is the most important structure. Mean heart dose, there are studies, if your mean heart, although we accept up to 20 gray in various studies, mean heart dose beyond 10 gray in quite a few studies have shown trouble, like ventricular dysfunction and various other things. So trying to keep a mean heart dose around 10 to 12 gray is not a bad idea.
Yeah. As can be seen on the slide that the mean heart dose is more than 11 gray, then there is a higher likelihood of the cardiac event. But I wanted to ask my panelists, what will be your priority? Because lung cancer is just that here you have the lung, and in anterior you have the heart, and there you have the posteriorly spinal cord. Then what will be your priority? The lung, which is an immediate or acute side effect, or a heart, which is going to be 5 year or 10 year down the line, will be impacting your overall survival. So what you will choose, and what do you choose routinely?
So lung over heart, if there's a trade-off.
So after Nikhil's presentation, everything. Because EDIC eventually will take every doses. Lung, heart, everything. Your tumor volume, fractions.
So in
I
the
think the lung is most important in the immunotherapy and TKI area.
yeah, but so the heart will take a backseat then. Yeah, because it's not humanly possible that if you want to spare the lung, then you will have to deposit the doses in the heart, maybe on the right side or in the left side, so depending upon the side of the tumor, and you can use the motion management. But now coming to the fourth trial, this is a very exciting abstract. I've read it for the first time. The estimated dose to the immune cell, and they have shown that the continuous and the categorical variable EDIC is a significant prognostic factor for overall survival. And we all know that the lymphocytes are radiosensitive, and we treat the thoracic malignancy with a mediastinal blood pool. So we are radiating the mediastinal blood pool. But what is your take on the estimated dose to immune cell as a OAR? Means, how do you want to incorporate that in your clinical practice? Is this just for the publication's sake, or is there a clinical importance also?
See, it will be of a clinical importance, but what I feel is actually to estimate calculate your EDIC is going to be difficult. So we need to have a surrogate, two things we can still manage is the mean lung dose and the mean heart dose. Because the third variable, the ITDV, is going to be difficult to estimate because it depends on how much you have scanned also, the weight of the patient, the number of fractions which you are treating. So it has a multiple variables.
BID regimen is coming into the picture.
These are different things altogether. So to measure that ITDV will be a difficult task. But at least if we can control the two of the other parameters, then yes.
Mean heart dose and mean lung dose.
Mean lung dose. So that two parameters can achieve that, we will reduce the EDIC whatever way we can.
I wanted to ask Srinivas, so what is the role of particle therapy in the estimated dose to immune cells? Because they have commented on this particular topic that maybe the flash therapy or particle therapy will reduce, as we all know.
Yeah, I mean, on one hand, we just heard from the panelists that the mean heart dose has very little relevance, and in fact, the meaningless. It's called mean heart dose. Basically, mean heart dose is meaningless essentially, and the no dose constraint to the heart is actually very relevant. And the EDIC is very exciting, especially for particle therapy, because the integral dose comes down, the low to intermediate dose wash comes down. Therefore, I feel there is a benefit in some patients. Definitely in almost all patients, especially the low primaries, N3 nodes, bulky N2 disease. These are the 3-4 areas where I feel that particle therapy has a big role to play.
So in the interest of time, I just like to summarize, sorry for rushing it fast. IMRT with SIB needs more evaluation in small cell lung cancer. The SPATU trial, the aggressive radiation therapy and systemic chemotherapy might hold a better future for us. Heart doses are important. There is no absolute cutoff. There is no absolute what we need to see. We need to follow up. So ALARA principle is the most important thing. And the EDIC is an exciting data, but I feel that it needs more validation because the definition and the formula are two different things in both the paper, RTOG 0617 and your paper also. So it is going to be slightly difficult. It will need more validation. So I would like to thank all my panelists for this wonderful
Anil,
time.
I
Yes,
just
please.
wanted to, meaningless meaning of mean heart dose cannot be overemphasized. That is what I wanted to
I
say.
wanted to comment on that, but I just left it. Okay, thank you very much for all your time.